is drug therapy of peptic ulcer. In this part of the video lecture, we will be discussing the definition of peptic ulcer, the signs and symptoms, the types of peptic ulcer, the factors regulating gastric acid secretion from the parietal cells, and the drug therapy of peptic ulcer. So we will be focusing our attention on the drugs that neutralize the gastric acid secretions, that is the antacids, and the remaining drugs will be covered in the next part of the video lecture. How do we define peptic ulcer? Peptic ulcer is defined as a break in the lining of the stomach or the first part of the small intestine or sometimes the lower part of the esophagus. An ulcer in the stomach is called as gastric ulcer, and the ulcer in the first part of the small intestine is known as duodenal ulcer. The signs and symptoms of peptic ulcer are waking at night with upper abdominal pain or abdominal pain that gets relieved with food. While in gastric ulcer, the abdominal pain gets aggravated or gets worsened with food. The other symptoms are belching, vomiting, loss of weight, poor appetite, and so on. The complications are bleeding, perforation, or blockage of the stomach. Next is the pathogenesis of peptic ulcer. Peptic ulcer is due to an imbalance between the gastroduodenal mucosal defense forces and the aggressive forces. The aggressive forces are increased acid pepsin secretion, Helicobacter pylori bacteria, NSAIDs and corticosteroids, smoking and alcohol. The defense forces are mucus secretion, bicarbonate secretion, stimulation of prostaglandin production, and increased mucosal blood flow. So an imbalance between the aggressive forces and the defensive forces can lead to ulcer formation. Next, what are the factors that regulate gastric acid secretion from the parietal cells? Three types of stimuli regulate gastric acid secretion: neurologic stimuli, physical stimulus, and hormonal stimulus. Neurologic stimulus. Stimulation of vagus nerve enhances the release of acetylcholine, which acts on muscarinic receptors, in particular the M3 receptors located on the basement membrane of the parietal cells of the gastric mucosa. Stimulation of M3 receptors activates the phospholysis CYP3-DAG pathway, increasing the concentration of calcium. So increased concentration of calcium activates protein kinase A enzyme, and this leads to activation of the proton pump, that is mediated by hydrogen potassium exchange pump. This causes hydrogen to move out in exchange for potassium. Hydrogen that is removed out of the parietal cell combines with the chloride ion and forms hydrochloric acid. The next is physical stimulus. Physical stimulus causes gastric distension, leading to release of gastrin. Gastrin causes activation of IP3-DAG pathway, increasing the concentration of calcium, and increased calcium concentration activates protein kinase A enzyme, leading to stimulation of proton pump, causing hydrogen to move out and potassium to move in. Hydrogen combines with chloride to form hydrochloric acid. The third stimulus is the hormonal stimulus. Histamine is released in response to the vagal stimulus and the gastrin release, and it binds to H2 receptors located on the parietal cells. The H2 receptor activation leads to the stimulation of adenylyl cyclase enzyme, increasing the cyclic AMP formation. Increased cyclic AMP causes activation of protein kinase A enzyme, causing activation of the proton pump and leading to the secretion of hydrochloric acid. In conclusion, neurologic, physical and hormonal stimuli control the gastric acid secretion in the stomach. So how do we treat peptic ulcer? The drugs that are used for treating peptic ulcer can be classified as drugs that neutralize gastric acid secretion. These include antacids. The antacids can be further subclassified as systemic antacids and non-systemic antacids. The systemic antacids are sodium bicarbonate and sodium citrate. The non-systemic antacids are further classified as buffer type and non-buffer type. The buffer type non-systemic antacids are aluminium hydroxide, magnesium trisilicate, magaldrate. Non-buffer type non-systemic antacids are magnesium hydroxide and calcium carbonate. The next category is drugs that reduce gastric acid secretion. These are antimuscarinic agents, H2 receptor antagonists, proton pump inhibitors, and prostaglandin analogues. The next category includes drugs that act as ulcer coating agents such as sucralfate and bismuth subcitrate. Then also we have ulcer healing drugs which includes carbenoxolone sodium. And lastly, we have the H. pylori regimen which includes various antibiotics such as amoxicillin, clarithromycin, metronidazole, a proton pump inhibitor such as omeprazole and bismuth subsalicylate. Next we move on to the drug therapy of peptic ulcer. The first category is drugs that neutralize gastric acid secretion and are known as antacids. Antacids are weak bases that neutralize gastric hydrochloric acid and raise the pH of the gastric contents. By raising the pH of the gastric contents, the pepsin activity is reduced. Also, they promote protection of the mucosal membrane by stimulating prostaglandin synthesis and increasing the mucus production and forming a protective layer of the mucosa. Antacids provide immediate relief of symptoms unlike the drugs that reduce gastric acid secretion because antacids neutralize the acids that are already formed in the stomach and the intestine and hence they provide immediate relief. But drugs that reduce gastric acid secretion are longer acting and take time to act. The antacids are classified as systemic antacids and non-systemic antacids. The systemic antacids include sodium bicarbonate and sodium citrate. Sodium bicarbonate is highly soluble, rapidly dissolves and has an immediate onset of action. So it provides immediate relief of symptoms. However, it has numerous disadvantages. Sodium bicarbonate when combines with hydrochloric acid forms NaCl, that is sodium chloride, water and carbon dioxide. However, sodium bicarbonate has numerous disadvantages. Sodium bicarbonate combines with hydrochloric acid and forms sodium chloride, water and carbon dioxide. Carbon dioxide causes belching and causes gastric distension, stimulating the release of gastrin. So this can lead to rebound acidity. Sodium chloride increases the sodium load and aggravates clinical conditions such as hypertension, edema, congestive heart failure and so on. The unreacted alkali, that is bicarbonate ion, gets reabsorbed into the systemic circulation and can cause metabolic alkalosis. So although sodium bicarbonate provides immediate relief of symptoms, it has numerous side effects such as rebound acidity, increased sodium load and metabolic alkalosis. The next is non-systemic antacids which are further subclassified as buffer type and non-buffer type non-systemic antacids. The buffer type of non-systemic antacids have a slower onset of action and a longer and sustained duration of action. The rise in pH is from 3 to 4.5 and this decreases the activity of pepsin. So rebound acidity is not a problem with buffer type of non-systemic antacids. The buffer type of non-systemic antacids includes aluminium hydroxide, magnesium trisilicate and magaldrate. Both aluminium hydroxide and magnesium trisilicate neutralize hydrochloric acid in the stomach and forms aluminium chloride and magnesium chloride. Both aluminium chloride and magnesium chloride interact with the intestinal bicarbonates and form aluminium carbonate and magnesium carbonate. Since the intestinal bicarbonates are utilized in the reaction, there is no bicarbonate ion to be absorbed into the systemic circulation. So the acid-base balance is not disturbed with buffer type of non-systemic antacids. However, magnesium carbonate causes osmotic diarrhea, and since diarrhea is a side effect of magnesium carbonate, it can be administered along with aluminium hydroxide, which has constipating action. So both the effects counterbalance, and administering both the agents together reduces the impact on bowel movements. The next buffer type of non-systemic antacid is magaltrate, which is hydrated complex of aluminium magnesium hydroxide sulfate complex. So this salt combines or neutralizes hydrochloric acid and releases aluminium hydroxide and magnesium hydroxide. Aluminium hydroxide is a buffer type of non-systemic antacid with less chances of rebound acidity, slower onset and a longer duration of action, whereas magnesium hydroxide is a non-buffer type of non-systemic antacids. So this was about the buffer type of non-systemic antacids. Next we talk about the non-buffer type of non-systemic antacids, which includes magnesium hydroxide and calcium carbonate. Calcium carbonate neutralizes hydrochloric acid and forms calcium chloride, and carbon dioxide is released. Calcium chloride stimulates the gastric mucosa to release gastrin, and carbon dioxide that is released causes belching and causes gastric distension and sudden rise in gastric pH. Due to a sudden rise in gastric pH, there is a chance of rebound acidity. Excessive doses of calcium carbonate when administered along with milk causes milk alkali syndrome, which is characterized by hypercalcemia, metabolic alkalosis and renal insufficiency. Magnesium hydroxide on the other hand neutralizes hydrochloric acid of the stomach and forms magnesium chloride, which in turn combines with intestinal bicarbonates to form magnesium carbonate. The chances of rebound acidity is less compared to calcium carbonate, which releases a lot of carbon dioxide. So magnesium hydroxide does not release carbon dioxide, so rebound acidity is mild and is for a brief period. To summarize the effects of drugs that neutralize gastric hydrochloric acid known as antacids. Antacids are weak bases that neutralize gastric hydrochloric acid. They can be classified as systemic antacids and non-systemic antacids. Sodium bicarbonate is an example of systemic antacid. It is highly soluble, rapidly dissolves and provides quick relief of symptoms, but it has a lot of drawbacks. Carbon dioxide release causes belching, bloating and rebound acidity. Sodium chloride reabsorption increases sodium retention and aggravates conditions of edema, hypertension, congestive heart failure and so on. The reabsorption of bicarbonate ions into the systemic circulation causes metabolic alkalosis. The disadvantages of systemic antacids can be overcome by the use of non-systemic antacids, which can be subclassified as buffer type and non-buffer type of antacids. In buffer type of antacids, we have aluminium hydroxide, magnesium trisilicate and magaltrate. The buffer type of non-systemic antacids are slow in onset and act for the sustained duration. Also, the problems of rebound acidity are less with buffer type of non-systemic antacids compared to systemic antacids. In non-buffer type of non-systemic antacids, we have calcium carbonate and magnesium hydroxide. Calcium carbonate releases a lot of carbon dioxide and causes belching, bloating and rebound acidity. Excessive doses of calcium carbonate when ingested with milk causes milk alkali syndrome characterized by hypercalcemia, metabolic alkalosis and renal insufficiency. Magnesium hydroxide on the other hand can cause osmotic diarrhea, therefore it is administered with aluminium salts which are constipating in nature. This brings us to the end of the topic. These are my references. Thanks for watching. Please like, subscribe and share.